Okay, welcome to Fridays with Feldman, May of 2023. Today with Fridays with Feldman, we're going to discuss a pretty esoteric topic or a pretty rare condition called Escobar Syndrome. And joining me today will be Dr. Kaveh Asadi, who's a pediatric neurosurgeon. With Escobar Syndrome, there's multiple doctors who are involved in treating multiple parts of the body in children and adults with Escobar Syndrome because there's multi-systems that are involved. Arthrogryposis has many different types. Escobar syndrome is one form of arthrogryposis, which just means stiff joints. It is a genetic disorder, mostly autosomal recessive, meaning that it comes from both parents. And the children who have it have either one of two genes. We go back one slide. Either one of two genes, either the CRHRNG gene, and more commonly recently described the TPM2 gene. But basically, these genes affect the ability for a neurotransmitter. I don't know how much anybody knows about myasthenia gravis, but basically, it's a weakness of the muscles, but it also causes things that we see in orthopedics, such as webbing of the knees, webbing of the hip, webbing of the neck. And those are called pterygium. That's the fancy word for them. And it involves the hips, the knees, the spine. Oftentimes the spine is fused in different locations congenitally, and that will cause a pretty severe scoliosis, which is a curve to the side, a kyphosis, a curve, the knees are bent. And in this pterygium syndrome, that's what a pterygium looks like. It's a webbing. Now, the problem for me, in getting the knee straight and to walk is the sciatic nerve often just runs right in the back, or the tibial nerve runs right in the back of the knee. So to straighten the knee, you'd think this rubber band in the back of the knee is basically just so tight. So in terms of doing that, there are many tricks that we have to allowing us to get the knee straight. The good thing about Escobar syndrome, unlike some other forms of arthrogryposis, is that usually the kids are quite strong. The muscles are present. So basically, you can start with different types of pterygium. That's one. There's another pterygium. And these are all before the patients are undergoing releases of the knees, similar that I've described in arthrogryposis, and you can watch some of those slides on my website and some of those talks I've given with Fridays with Feldman. I'm not going to review that, but needless to say that this is lying, prone if I'm going to lengthen the skin as well. But that's actually the nerve. The nerve sits all the way back, and that's why I'm showing this slide. And there, the child, you can see it even kind of webbing of the hip. Next slide. And this is afterwards, one side was done, and you can see that the knee can go fully straight, you can get rid of the webbing, and you can also make the knee bend as well. So it's not just about getting the knee straight, which we can do, and if you watch the arthrogryposis slides, there's many pictures of kids walking with Escobar syndrome, so no matter how bad the pterygium, no matter how bad the webbing, there are methods, without external fixators, that we can actually have the knees at least mostly straight, and the children walking. And most of my children with Escobar syndrome do walk. But I think that when you look at an Escobar child and when you discuss treatment with them, you're going to discuss with them, we're going to treat your scoliosis. We may treat your knees. We may treat the webbing of your hip, the webbing of your neck. And one thing that's often ignored, and that's why really the purpose of this Fridays with Feldman was to discuss, is the neurosurgical part. That has been something that most pediatric neurosurgeons don't focus on in arthrogryposis in general. And they certainly don't focus it on in Escobar syndrome. And so that's why I actually asked Dr. Asadi today to speak to us about some of the neurosurgical findings in Escobar syndrome. So I think if you watch my videos on arthrogryposis and some of the talks I've given, it's really the same for me for Escobar and arthrogryposis with minimal changes in the fact that I've got to get rid of that webbing. But in the neurosurgical part, that's the part we're trying really to go out there and show all the neurosurgeons in the country and in the world that these conditions can often be improved by neurosurgical treatment as well. So I'll give it over to Dr. Asadi, who's a terrific neurosurgeon, so I'm sure he'll be able to explain this to you better than I can.
Well, thanks for having me, David. So I just wanted to talk a little bit about the tether cord syndromes, which is very prevalent in Escobar's and other kids with arthrogryposis. And to put things into a little bit of perspective, what tether cord is, usually the spinal cord, which is the connection from the brain to the rest of the body, it's a free-floating tube within the body, and at the very bottom of the spinal cord there is a tiny little string which we all have. It's called filum terminale. It's like a little string, very flimsy, couple millimeters thick. and it allows the spinal cord to be free floating and free moving regardless of what the body is doing. And in kids with tether cord who are born with a thicker phylum, if you imagine if this would be like, can you see that okay? If this is like, the equivalent to like, a normal phylum terminale, this would be more the equivalent to like, a thicker one, or sometimes not infrequently in kids with Escobar, we see the phylum to be very thick. And what the thickened fibrous phylum does, it prevents the spinal cord to be free floating, but more importantly, as the body grows, it starts stretching the nerves and the spinal cord accordingly. And those problems don't just start like, after a baby is born. They can already be present at birth and as the baby is growing and then into toddler age. And then the problems a child can be experiencing, like with a tether cord, it's twofold. One is related to problems which are obviously related to the nerves, weakness, numbness, tingling, or issues with bowel or bladder. Those are the patients which usually would show up in my office. Unique to pediatric orthopedic offices when those kids show up with joint deformities or let's say predominant toe walking, and that's where really the multidisciplinary approach within the Paley Institute comes into play, that we evaluate all those kids together, review all the imaging carefully together to make sure that no underlying condition, especially like tether cord, is missed.
So I think the other part of this is that there's other things in Escobar syndrome, even from a neurosurgical standpoint, other than just tether cord. So tether cord is treated surgically, is that correct?
That's correct.
And how do you treat it?
So tether cord, it's being a mechanical problem, meaning the phylum being too thick and under tension. We have to make a small opening about 1 inch in the lower back, remove the bony spine to expose the nerves and the phylum, and then cut the phylum with tiny little scissors to release the tension.
And then the reason why I think that's so important from an orthopedic standpoint is that if that's not done, many times whatever we do to the lower extremities will recur. So if the knees were very tight before, they'll get tight again, because the body, if you want to look at it very simplistically, doesn't want to stretch any nerves because it's so stuck on the spinal cord. So the releases are very important. The other part that I think that you get involved in is from below the base of the brain, right? So that's the other thing in Escobar syndrome that can occur. And you want to describe, that's also in some other conditions like achondroplasia and things like that, but certainly in Escobar we've seen it as well.
Yeah, so they can also develop a condition which is called foramen magnum stenosis, where the area where the skull is sitting on top of the neck becomes extremely narrow, and that's a area where there are a lot of very important parts of the brain, sleeping centers, heart rate, eating, drinking, but also moving parts of the center which can be all affected as a result of the tightness or the stenosis. And that is can sometimes become very severe, significant, or even life-threatening in rare instances.
Many people talk about when we should do Escobar syndrome MRIs. I think the child, obviously, if you get it too early, then it depends upon what we're looking for.
Within the
foramen magnum stenosis, we certainly want within the first 6 months, because that's, as Dr. Asadi is describing, can cause sleep apnea and things like that. Certainly the child can have sleep study before they do that. The MRI for the spinal cord, usually we get it somewhere within the first year of life to make sure that the spinal cord is not tethered. And then usually as soon as we do see it's tethered, then we automatically have that surgery, which is not a very large surgery in general, but it is a very effective surgery. So, as an orthopedic surgeon who doesn't do that surgery, it's something that I'm so in favor of that I'm on my podium talking about the fact that I think this neurosurgical procedure is essential for children who have Escobar syndrome, and certainly other children with arthrogryposis who have a problem. We'll be collecting all of our data soon and publishing this on the percentage of patients with arthrogryposis who have tethered cords, but certainly in the genetic forms of arthrogryposis, such as Escobar and some other forms, those are the more commonly ones where we're seeing that the children have the tethered cords, as opposed to just pure AMC. So I think that this is going to be certainly discussed further, because there is not a connection that the orthopedic surgeons have with the neurosurgeons in this regard. There's a disconnect, actually, and I think we're trying to make that connection, basically more and more, and is why we're discussing it today. So I think if your child does have Escobar syndrome, or you do, I think that the management of it is an MRI or a sleep study early on, an MRI within the first year of life, having it assessment of everything, assessment of the tonsils, and with an ENT, assessment of by a neurosurgeon, assessment by an orthopedic surgeon, sometimes we include plastic surgeons, sometimes for some of the pterygiae. And I think those are really the crucial parts, that sometimes ophthalmologists in terms of the eye drooping. So there are various parts of this condition that need to be treated simultaneously often. And I think that it is not a common condition, but it's one that we see commonly, and so that's why we're discussing it. And I really appreciate your discussing it with us today. And I think that
Absolutely.
I've been working with Dr. Asadi for about a year and a half now. I think that and before that I was at NYU, and also was the same thing. This joint venture of working with neurosurgeons and orthopedic surgeons is crucial for these very complex conditions. So thanks for listening today. We'll be back soon, and if I don't see you before the summer, have a happy summer, and signing out, Professor Feldman. Thanks, guys. Thanks for listening.